Our evidence-based practice project was about a child who is late to talk. I'm Charleston Matson.
I'm Sydney Bourgeois.
I'm Adriana Sanchez.
And I'm Caitlin Sander.
So for our case study, we had a 2-year-old who has less than 50 words, and he was also not combining any words. So basically, he had a language delay that was defined as the failure to develop age-appropriate language abilities. He also had 2 young siblings, and we did have an SLP treating him at home. The child tends to get frustrated when they don't get what they want, and they were consistently using the same gestures and pointing to try to communicate, but it wasn't really working, so the child would get frustrated. Populations that are more likely to have delays in language are primarily in males and children who live under the poverty line. We also do have children that have a minority status, and also the sibling order is very important because typically the youngest child tends to have a delay in language. Also, living in a single parent home, whenever children don't get spoken to a lot, that's also when they will tend to have language delays. So for our assessments, we did the preschool language skills and the MacArthur Bates communication development inventories in order to assess language, and we also did collect a language sample from our client. For PICO, we had our patient who is a 2-year-old boy with a language delay. His vocabulary is around 50 words, and he has also shown no indication of combining words when he's speaking. The intervention considered is parent training through the Teach, Model, Coach, Review instructional approach. Our comparison treatment is a melodic-based communication therapy, and the desired outcome for this child is to have him reach an expressive language level similar to his age group.
Our first technique was the Teach, Model, Coach, Review approach. This article has a level of evidence of 3 because it is a well-designed, non-experimental study. 4 different parent-child dyads participated in the study, with the children ranging in age from 22 to 42 months, which is about the same range as the child in our case study. Every child had a language impairment as well. Caregivers attended 2 sessions a week that were each 40 minutes long for 12 weeks to learn different language support strategies. These strategies included matched turns, expansions, time delays, and prompting. This approach follows a cascading effect in that the caregiver learns the language support system strategies, the caregiver implements the strategies, and the child's language improves. The purpose of the study was to find what effects of the Teach, Model, Coach, Review approach on the caregiver's use of the 4 different strategies. And it also wanted to know what are the effects of teaching caregivers to use language support strategies on children's expressive language skills, as opposed to just teaching the children themselves. So, the procedure of the approach is as follows. First, you had to establish the client's baseline, just like always. Then you teach the 4 intervention strategies. Remember, they are matched turns, expansions, delays, and prompting. You teach all of them to the caregivers. Third, the caregiver plays with the child for 10 minutes using the strategies. Fourth, the interventionist reviews the session with the caregiver and tells them what was good about the session, what was bad about the session, etc. Lastly, the hope would be for the intervention strategies to be generalized at home, and that would be the caregiver using the strategies all throughout the day, 7 days a week, especially because an SLP can't be there all the time. In this study, 3 of the 4 children made significantly higher scores on the PLS-4 after treatment as opposed to before the treatment.
The second technique we used was melodic-based communication therapy. We decided this was a 1B level of evidence, which is a well-designed, randomized control study. This consisted of 12 participants, all with autism, and they ranged from ages 5 to 7. And they chose this age range because by age 5, it is extremely hard for a child with autism to acquire language. We split it up into 2 groups. We had the traditional process group, which is imitation, independence, and then 2 words. So you would imitate with the clinician, then do it independently, and then add 2 words. And then we had the MBCT group, which was an 11-step process. So first you would listen to the recording of a word set to a melody, then you would do a hand-over-hand clap of the rhythm. Then there would be a unison clapping of the rhythm with both the client and the clinician. Then there would be independent clapping of the rhythm. Then there would be clapping of the rhythm while singing to a recording with the clinician. Then there would be clapping and singing with just the clinician. And then we would have singing with the clinician without clapping. And that would progress to singing while the client mouthed. And then singing a word independently. And then you would answer a sung question with a sung target word. And then you would answer the spoken question with the spoken target word. And both groups had the same 25 target words and stimulus items. And it lasted about 5 weeks. And so there was significant progress seen in both groups for number of verbal attempts, but there was significantly more verbal attempts expressed by the MBCT group as compared to the traditional group. There was also significant improvement in number of new words heard for the MBCT group, and there were significant changes in the number of new words heard for the traditional group. However, there were no significant changes in number of new words heard for both groups combined, and the MBCT group showed significantly greater gains in imitative attempts as compared to the traditional group. And it is also important to note that the MBCT group had significant improvement in weeks 1 and 3, while the traditional group didn't make significant progress until week 4 or 5.
We decided that the teach, model, coach, review approach would be best for our client because it would allow the parents to be involved in treatment, so specifically because of that cascading effect. Teaching the parent will carry over out of therapy and into everyday life. We also agreed that melodic therapy would be too high of a level for a 2-year-old. So we developed a little bit of a management appraisal plan composed of 1 long-term goal and 4 short-term goals. Our long-term goal was for our client to improve overall expressive language skills, to increase vocabulary, and accurately combine words. Our first short-term goal was the client will accurately produce 2-word utterances with parent in structured activity with 40% accuracy given maximum cueing. We chose this a goal. We made this a goal because kids should be combining words around 24 months. Our second goal was that the client will accurately respond to directions containing spatial concepts given 1 verbal cue and 1 visual cue with 50% accuracy. We made this a goal because 2-year-olds should be able to follow 1-step directions that include prepositions. So an example of this would be place the ball in front of the chair. We also took the approach that since comprehension comes before production, this could expand his expressive skills. The third goal was the client will accurately pair words with existing gestures given 1 verbal cue with 50% accuracy. Since he's already using gestures to make requests, we should use that to our advantage and pair those gestures with words. A good intervention technique for this goal would be what we know as materials control, where he doesn't get what he wants until he accurately verbally expresses it. Our fourth short-term goal was that after parent modeling, client will accurately produce common food vocabulary words in structured activities at 50% of the time. We picked food items because this applies to daily functioning. 2-year-olds should have 200 to 300 words, and our client has less than 50. We'll have the caregiver model the correct words to increase the child's vocabulary. So for the summary, our client is 2 years old, has only 50 words, and is not yet combining words. We compared 2 treatment approaches, 1 melodic-based and 1 caregiver training-based. We decided the teach, model, coach, review approach would be best for our client because it would involve the parent. We wrote 1 long-term goal targeting expressive language And then we wrote 4 short-term goals targeting combining words, responding to directions, pairing existing gestures to new words, and producing common food words.